Great. Well, I want to thank the organizers for having me and thank you for taking the time to look at my poster or my video, but I'm going to be talking about testing network prediction of drug combination effects using electronic health record analysis. And so the primary assumption in this particular study is that what we previously knew is that drug-drug interactions tended to be regulated by what's known as a shared protein mechanism. So in this cartoon, two triangles share one protein, and that can be a target, a transporter, or an enzyme. But the goal of the study was to test the idea that network protein mechanisms could also govern drug-drug interactions. And so in this scenario, the two drugs don't share a protein target, but their protein targets share some downstream interaction. So we specifically studied these particular relationships and eliminated the shared protein mechanisms. And then for this particular study, just to give you a sense of the data that we were using, we did extract data from drug labels, and we looked at a set of severe adverse reactions. So those are the column on the right. So there's about 34 of those, and just to give you a few examples of them. And then there were about 1,970 drugs, and those are the triangles on the left. And just to say that we took severe adverse reactions from the warnings, box warnings, and precautions of the drugs labels. And so we didn't look at all side effects, just severe side effects. And what we did is we came up with this novel network classification method where on the top left, what you see in the sort of brown box is that we modeled 5 different drugs. So 3 of them are on the left and 4 and 5 are on the right. And we modeled them with the PathFX algorithm, which I can't talk about in this particular recording, but I'm happy to talk about in the Q&A. And for drugs 1, 2, and 3, they were all connected to sepsis using downstream protein interactions, but they had a common protein in their network. So they became the A network class, where drugs 4 and 5 were associated with sepsis, but they didn't have protein A in their network. So using these network classifications, we made predictions using the blue triangles in the bottom left. And what you can see is that we kept drug A2 because it bound protein A, but shared no other targets with the drugs 1, 2, or 3. Where drug A1 was eliminated because although it bound downstream protein A, it also shared a target with some of the drugs in the class. And then this is simulated data, but just to show you how we designed the target and comparator cohorts for the observational study. On the bottom left, we went back into the electronic health record and asked for patients who were taking either drugs 1, 2, or 3, or the network class drugs versus the non-network class. And first did a baseline characterization of the relative risk, for instance, for sepsis between the two classes. And then in the row above that, we then added drug A2 and asked for the relative risk if you had a combined exposure between A2 and one of the network class or the non-network class drugs. And then we took the ratio of those hazard ratios, and that's shown on the right. But just to say, as we did this pipeline, we also first looked at published resources. And so I won't go through all of this because this is a very brief summary, but just to give you a sense of what the numbers are and how many predictions we started with. And basically this shows sort of the narrowing of that data set. And we first turned to two sides, which is one of the more popular data sources of known drug-drug interactions. And we took out drug-drug pairs in our analysis that were not prescribed in the real world before we actually did this electronic health record analysis. And then we further went back to two sides and said, for the drug-drug interactions, are we predicting the correct outcomes? And we found that we had about an 80.7 sensitivity for predicting drug-drug interactions when we again eliminated all drugs that had some known shared protein target. Then to give you a flavor of what came out of the electronic health record analysis, I've highlighted 2 examples here. So on the top, we have the TEN network class, which meant that the networks had P53, EDNRA, or NF-kappa B IA downstream. And we again measured the relative risk without the combo between the network and non-network class, and then with the combo. In this case, aspirin, if you look in the far upper left there, was the predicted combination drug. And importantly, aspirin was not associated with pancreatitis on the drug label, but was only associated with pancreatitis when used in the background of these other drugs. There's another example here where we did an analysis again for sepsis. And this time the network class was defined by the adrenoreceptor beta 2 in the network. And then the combination drug was albuterol, but also known as salbutamol. And that drug was not associated with sepsis on the drug label, but was only associated with sepsis when used concurrently with one of the network drugs. So the conclusions for this brief introduction to the study are just that we predicted drug-drug interactions using protein interactions between their targets. And we did eliminate drug-drug pairs with shared targets, saying that many drug interactions can have these long-range effects. Our classification method had a pretty high sensitivity when benchmarked against gold standard data sets. And then further that we could go back and do novel electronic health record analysis to support these predictions. And we have a few other predictions that didn't fit into the slide, but are on the poster. And then lastly, the study provides support that PathFX identified proteins are part of the drug's pathway. So it was unclear previously if those downstream proteins were actually part of the drug effects or just sort of periphery to the prediction. So thank you for your time, and I hope you come by for questions either virtually or in person.